Hello, everyone. My name is Sorcha Martin, and I'm a practicing physical therapist and faculty member at Boston University. I treat at the Boston University Physical Therapy Clinic, and my focus has been on orthopedics and manual therapy. I teach a clinical medicine class for the DPT students here at BU. This course includes an introduction to contemporary pain science classifications, and pain treatment. So today, I'd like to share with you our best current understanding of contemporary pain science, classifications of individuals with pain, and treatment of pain. I hope to do this with as much clinical context as I can and with as many clinical examples as I can. So unfortunately for me, I have no financial disclosures to report. I will mention some resources that I use in my clinical practice, but I have no relationship with any of the authors or organizations. I don't get any financial kickback should you choose to utilize any of these resources in your clinical practice. So if you feel like buying a book, I don't get any money back from that. Okay. So my objectives for this talk include identifying current concepts of pain science and nociception, identifying the physiological mechanisms of both acute pain and persistent pain, identifying physiological changes that occur in patients with persistent pain and patients with central or spinal sensitization. I'll also identify pain treatment and pain classifications, along with current best practice treatments for each unique classification. So I think it's helpful to start this conversation by asking the question, why do we hurt? And why do we experience pain? Physiologically, what's the benefit to experiencing pain? If we look at individuals who never experience any pain, people with congenital insensitivity to pain, these individuals, of which there are very, very few, only a few several hundred that we've known about, since the first individuals have been identified in the late 1990s. And these individuals actually tend to die quite young because they injure themselves frequently and often quite severely. Without any pain experience, they never learn not to drink fluids that are too hot. They don't have any feedback to let them know how close they are to the edge of what their body can actually tolerate. There was actually a piece published in the New Yorker this past January of 2020, about this very topic, and it's actually a really interesting read. So if you're looking for some light reading, you can look that up. So we currently understand from an extensive body of literature that we experience pain as a way to keep ourselves safe. It's designed as a protective mechanism to draw attention to the threats to our well-being. So if we look at the work of Paul Hodges and his colleagues that have emphasized that experiencing pain helps us change our movement patterns to protect tissue that might become vulnerable, nobody teaches you how to limp, for example. If you sprain your ankle, you limp, and that's an altered movement strategy that emerges in response to pain, and it's a way to help protect that tissue. Pain also allows us to learn what movements, activities, or tasks are safe for us to do, with the goal of preventing injury recurrence. So having a healthy pain response is very biologically advantageous. So if we look at the images on the top of the slide here, we have Lindsey Vonn skiing herself down the mountain side after a crash, which required her arms to be immobilized. Sorry for all the Celtics fans out there, but this second image is of Gordon Hayward on the floor with his left ankle looking suspiciously like it might be in some trouble. You don't need to be an ortho PT to see that his ankle here is not okay. We have a poor Tour de France cyclist taking a tumble from his bike and a bull rider headed for what is sure to be a pretty substantial impact with the ground. Right? Each one of these individuals is likely experiencing some degree of pain. So how much pain, when and where they feel it, however, is unique to them. Their prior experiences, the context in which these injuries happen, and their beliefs about pain are all drivers for how much pain they will be in. The severity of the injury actually has very little to do with how intense that pain experience is. Context, however, appears to be crucially important. So the International Association for the Study of Pain in 2017 defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So I think it's important to recognize that this definition is both sensory and emotional experiences are recognized as the role of both actual and potential tissue damages too. This will be a particularly important concept to think about when we talk about the physiological effects of persistent pain. So I think the importance of talking about nociception and how nociception and pain are not the same thing can't be underestimated. Clinically, when we talk about performing a neuroscreen, for example, we talk about testing sharp dull or pain and temp and the response of the patient. We're not actually testing pain in that moment. What we are testing is nociception. And the folks at the ISB define nociception and the detection of intense thermal, mechanical, or chemical stimuli by primary afferent sensory neurons. So this is a one-way system that relies on external stimuli to send a message to the brain. That's nociception. And this message occurs when free nerve endings, or nociceptors, and those are the danger messages, as I often refer to them when I'm talking to my patients about pain and nociception. And they live at the end of thin, non-myelinated axons, and they send information to the spinal cord. Spinal cord then passes along that danger message to the thalamus and then on to the brain. The brain then decides if that message is worthy of the body experiencing a pain response. Interestingly, that danger message can be mediated in the spinal cord. It can turn up the intensity of that message, or it can turn down the intensity of that message. And this all happens behind the back of the brain, so to speak. So the brain doesn't know the spinal cord has decided to turn up or turn down the intensity of a danger message that it's received. I think it's important to acknowledge that despite any changes the danger message undergoes on its path to the brain itself is the only mechanism to mediate pain. The brain alone can turn the pain up or turn the pain down. So to be clear, if there is sufficient stimulus to cause a nociceptor to fire, that information will travel to the spinal cord along slow, unmyelinated axons. Once it receives the message at the spinal cord, the cord can pass that message as is. It can increase or decrease its importance. That information goes up to the thalamus and to the brain. The brain then decides, outside of the person's awareness or control, and that's an important point, I think, to remember, that it's not a conscious decision to have pain. You have pain and a pain experience based on your brain's determination to keep you safe. So what information does the brain use to make that determination, right? It does rely on information from the periphery, including those nociceptors or those danger messages. It also relies on previous experiences, the task or the activity that you're doing when you got that pain message, the threat level of that activity. All happens within the context of what you're doing at that moment. So I'd like to give you an example from my own background. This handsome devil is Cash. He's a retired American thoroughbred, and in his second career, he was lucky or unlucky enough, as the case may be, to end up in my hands. And I compete in the sport of eventing. Many of you have probably never heard of that equestrian sport, and some of you might have heard of it and recognize it as the sport that Christopher Reeves was competing in when he had his spinal cord injury. So I promise this is relevant. So I was working with my trainer to get Cash more comfortable jumping in and out of water, which should look a little bit like this. I will say that's an Olympic level rider jumping, and we weren't doing nothing near that high, but that's just to give you a general idea. So Cash and I jumped off the bank, and unfortunately he got his feet tangled. In an effort to stay on, I wrapped my arms around his neck, and unfortunately, as his back legs were stuck on the ground, he hopped up behind and struggled to get to his knees. I still had my arms wrapped around his neck, and he went down on his knees and plowed a nice 3-foot strip into the ground with my head. So the good news is, at that point, I decided to let go. So I rolled off to the side, and he scrambled up the bank, and spoiler alert, he's fine. But my instructor came running over and asked if my arm was okay and if I was okay. And at this point, I had gotten onto my hands and knees and sort of laughed and said, my arm's fine. He didn't step on me. My neck, however, was not so fine. He was screaming at me. And, you know, as a physical therapist, I'm sitting there thinking about all the things that could be wrong, right? So in my head, I'm thinking, okay, number one rule of the Canadian C-spine mechanism of trauma, check, you know, I have that already. So since I was sort of up and moving, I figured no spinal cord injury, but given the large plow mark on the ground from my head and the fully flexed neck that I had, I was in my head thinking about, is my transverse ligament okay? What about the integrity of my dens? You know how it is when you have a little knowledge, it can be dangerous. So you'll all be glad to know that I declined to get back on the horse that particular day. But he and I did make it home safe and sound. Once I got myself situated and home, I was getting out of the shower and putting my hair up in a towel, and I noticed a little something on my arm. I had a perfect horseshoe-shaped bruise on my arm. 1,200 pounds of racehorse stood on my arm, and I never felt a thing. It was bruised, swollen, lumpy to palpate. There was significant local tissue damage, and it never once hurt. Not that day, not the next day, not ever. It was never painful. So physiologically, what happened? Did my arm nociceptors fail to deliver the message to the spinal cord? Unlikely. Did the spinal cord minimize the intensity of the message? Potentially. Did my brain say, oh, a problem in the arm, let me look around and see what else is happening? You think you have problems in the arm? Wait till you hear what the input from the neck has been. So given my past experiences, which unfortunately for me have included lots of horse falls that thankfully never really caused all that much serious damage, my understanding of what can happen in a neck trauma, specifically involving this task, I can thank Mr. Christopher Reeves for that. My brain is looking at all of this information and correctly identified that the bigger biological threat wasn't my arm, but it was my neck. So the nociceptive pathways delivered their messages from both the arm and the neck, but the brain ultimately decided where I should experience pain based on the context of that particular situation and with the goal of my overall biological safety. So as a result, it felt like my neck was incredibly painful and my arm never hurt me at all. So hopefully that story will give you some context for this next concept. Nociception is neither sufficient nor necessary for pain, but most of the time it is associated with some nociception. And that quote's taken from Lorimer Mosley's blog back in 2012 about pain being in the mind, but not in the way you would imagine. And it's worth exploring if you are interested in what really underlies that idea that you can have pain without issues in the tissues. Okay, so when talking about the mechanism of persistent pain, there are many factors and many potential drivers we think can contribute to a person's prolonged pain experience. So I'd like to start by talking about 3 physiological responses that we know happen in individuals with persistent pain. These include sensitization of the peripheral nociceptor, sensitization of the spinal nociceptor, and lack of precision or smudging that happens in the brain. So the image in the bottom right is a nice example of a loss of precision. I'm sure you've all had the experience of getting your thoughts muddled. I like this particular example. One brain cell says, have a nice day. The other says, have a good one. And the output given is a lack of precision, having nice gone, done. Right, so that's the smudging, that's the lack of precision. So during an acute injury, one of the mechanisms of activating the peripheral nociceptor is the presence of acute inflammation and the presence of acute inflammatory mediators. Most peripheral receptors attenuate with repeated activation, right? Meaning the more you ring them, the less sensitive they become. Nociceptors are the exception to this. The more they're activated, the more sensitive they become. So biologically, this is very sensible since their job is to notify you of danger, right? So with mounting danger, you don't want them turning down, you want them to be able to stay sensitive. So with that repeated exposure to danger, you don't want them becoming less sensitive. So firing of the nociceptor releases pro-inflammatory mediators, which further activate that nociceptive input. So this sensitization is normal and is a normal protective mechanism which helps protect the local tissue. It's actually quite valuable. Part of the inflammatory process is to then turn off this sensitization in the peripheral nociceptor. For some individuals, that peripheral nociceptor stays on and continues to perceive threats and reports them up the chain. The spinal cord and brain, however, don't know that the peripheral nociceptor is now sensitized, long past when it should be. So you may be familiar with the term central sensitization. Recent work from the Noy group and from Lorimer Mosley's research group suggests that the term spinal sensitization might be more accurate. This means that the spinal nociceptor has become sensitized, much like the peripheral nociceptor has. And that now requires less neurotransmitters to generate a danger message to send to the thalamus and to the brain. The spinal cord's new default setting might be to upregulate the danger messages it receives and requires less input to send those danger messages at all. So you may be familiar with the term ascending facilitation. This is when the spinal cord is turning up the intensity of the message it's receiving. The spinal cord also has neurotags, or little neural networks that represent parts of the body. The spinal cord, like the brain, which we'll talk about next, can lose the precision in those networks and cause the pain experience to spread and to be less precise. So when we talk about physiological changes in the brain with persistent pain, we're referring to a loss of precision in the neural networks that make up our pain experiences. We each have a network in our brains that make up neck pain, for example. So when all the cells for that network fire, the individual experiences neck pain. That neck pain network will share cells with the right shoulder pain neurotag, for example, and the left shoulder neurotag. So when I'm experiencing neck pain, only the cells in the neck pain neurotag are active. The non-member cells of the right and left shoulder remain quiet. In individuals with persistent pain, that precision goes away. My neck pain neurotag might also convince my right shoulder pain neurotag to fire. This meant instead of just experiencing neck pain, now I'm also experiencing shoulder pain. Thanks, brain. So the same thing can happen with my thoughts and beliefs about neck pain. For example, firing the neural network that worries about thinking about being able to go back to work and working on my computer may activate my worry about work neurotag, which shares some cells with my neck pain neurotag. Now just thinking about going back to work is making my neck hurt more. And this can happen without a single peripheral stimuli to the neck. The brain can change your pain experience without any input from the periphery. It can turn it up. This is called descending facilitation. The brain believes that the periphery is underreporting threat, so it makes the event very painful. You hear of stories of people who go to the emergency room with 10 out of 10 pain because they've stepped on a nail. When they get to the ER and the shoe is removed, the nail is sitting in their foot right between the two toes, zero tissue damage. No peripheral input, no danger messages from the nociceptors, no input to the spinal cord, but the brain sees a nail through the shoe and says, I must have stepped on that. I'm going to make that incredibly painful because it's dangerous. And so it experiences much pain so that you can do nothing else except get attention to fix it. Descending inhibition, on the other hand, is when the brain overrules the input it's receiving and turns down the pain experience. Soldiers in war often describe not feeling being shot or injured at an event, and it's not until much later that their injuries are discovered. People often attribute this to adrenaline, and yes, that's absolutely a part of it. But this is an example. But in this example, the brain has determined it's not biologically advantageous for that soldier to experience shoulder pain from that piece of shrapnel. Much better to have no pain and have the person's attention focused elsewhere. This is also an example of the benefit of peripheral sensitization. The brain turns off the initial warnings, but if the messages keep coming and it's biologically safe to do so, then the brain will develop and send a message of shoulder pain so that the individual tissue issue can be addressed. So some key points that we all should keep in mind should include the idea that pain and severity of pain does not correlate with tissue damage. So how much something hurt is not a reliable indication of how damaged the tissue is. All pain is an output of the brain, 100% of the time. Whether it's acute pain or chronic pain, the pain that you're experiencing is happening because your brain has decided it's biologically advantageous to attend to that particular threat. The pain experience is contextual and unique to that individual. So the idea that some people have higher pain tolerances or lower pain tolerances than others is sort of erroneous because you're comparing information that isn't relatable, right? So each person's unique pain experience is based on that particular context and their history. Acute pain and persistent pain can both be modified by the brain. You can have both ascending and descending modifications that happen at the brain. Persistent pain is a result of physiological changes, that is neuroplasticity, if you're familiar with that term, to the nervous system. And it can include, and does include often, peripheral sensitization, spinal sensitization, and cortical smudging. Okay, so hopefully that's enough pain science to give you a good review of the ideas that are not new to you. And if these are new to you, hopefully you have a good grasp of the main concepts. There are numerous resources on pain science, including many listed at the end of this talk, so please feel free to use these references as a guide. I'd like to move forward and talk a little bit about pain treatment. I purposely did not use the term pain management here, as it implies that pain is static and here to stay. And it seems to me that bioplasticity and adaptations in the nervous system are what cause persistent pain, so it stands to reason that bioplasticity can maybe work towards helping us treat pain too. So I would propose that utilizing a biopsychosocial model should be an integral part of all patient care, whether that problem is acute, subacute, or chronic. And the biopsychosocial model is an interdisciplinary approach that looks at the interconnection between the biology, that is the local tissue, the psychology of the unique individual, and that individual's unique socioeconomic factors. This is particularly helpful when individuals with persistent pain, where we know that drivers other than the biology or the local tissue can play a significant role. So Commenti et al. In 2018 published their work on pain classification in the Journal of Physical Therapy. They identified 3 biologically driven pain mechanisms: the nociceptively driven pain experience, nocioplastic driven pain experience, and the neuropathic pain experience. Given what we've already talked about today, I think it's safe to consider nociceptive pain to be a result of peripheral sensitization. These are your acute injuries. Of course, input from acute injuries are still susceptible to up and down regulation in the spinal cord and brain, but they are mostly driven by peripheral drivers. Nocioplastic pain experiences are driven by changes in central processing. Spinal sensitization, which we've talked about, is where you are likely to have patients who have developed allodynia, hyperalgesia, and perhaps even kinesiophobia. Neuropathic pain experiences are usually the result of a lesion or a disease within the somatosensory system. Neuropathic diabetic pain is a really good example of this. So I particularly like this graphic from Commenti's work as it demonstrates that regardless of what the biological driver is, whether it's nociceptive, nocioplastic, or neuropathic, they're all occurring within the context of that individual's motor task and within the framework of their unique psychosocial experiences. So if we talk about persistent pain, it's useful to know who is at risk for developing persistent pain. And there is a robust body of literature that purports that individuals who have anxiety or have depression are at a greater risk of developing persistent pain, as are people who have a family history of persistent pain. Their perception is often that they saw their family member suffer, so they're likely to suffer from those issues too. People who've been injured through trauma are also more likely to develop persistent pain, as are individuals with low self-efficacy. If an individual does not believe they're in control of what is happening to them, for example, if they're a victim of a car accident, they are more likely to be at risk for persistent pain. And people who have high fear avoidance and tend to have catastrophizing thoughts and beliefs are also at higher risk. So how do you as a clinician decide where your patient best fits? And it's worth noting that the image in the bottom right here suggests that there is potential overlap between the nociceptive, the nocioplastic, and the neuropathic pain experiences. And they are all affected by the motor system and affected by the psychosocial domain. So as we've mentioned, individuals who have nociceptively driven pain experiences are likely experiencing an inflammatory response. There is a mechanical input that's driving that experience, and that is often related to an acute injury. An acute ankle sprain, post-operative pain, and even osteoarthritis can easily fit into this category. And it's reasonable to say that the tissue is most likely the issue. Excuse my rhyming. So individuals who have nocioplastic pain are experiencing their discomfort because of central processing disruption. There's a lack of inhibition in the central nervous system and an elevation in the levels of excitation of that nervous system. These are individuals who are likely to have some central or spinal sensitization. Individuals with complex regional pain syndrome, persistent pain, or fibromyalgia are examples of individuals with nocioplastically driven pain. The local tissue might be a factor to consider, but it's not the primary driver of the patient's pain experience. And then individuals with neuropathic pain experience discomfort as a result of a lesion or a disease in the somatosensory system. These are folks with diabetic neuropathy, nerve compression, or complex regional pain syndrome, potentially too. It is worth noting that individuals with CRPS are also very likely to have significant nocioplastic contributions, so they do overlap between the blue and the green here, and that sort of fits perfectly with individuals with CRPS. So using this classification method, how does it drive treatment of physical therapy intervention? The graphic in the bottom right of our screen here shows different sections for nociceptive, nocioplastic, and neuropathic pain, along with considerations for both motor dysfunction and psychological considerations. Commenti et al. Suggests that each classification has different treatment interventions, but there are common themes across all classifications. Exercise, education, and some form of manual therapy are all recommended for each grouping. They suggest there is some evidence for TENS application in both acute pain and nociceptively driven pain, as well as nocioplastic pain. They also suggest that the value of TENS involves follow-up with exercise, and that TENS in isolation is not likely to be effective. In fact, you will notice that most of the interventions they are suggested are actually very actively driven and don't rely on passive modality interventions at all. So when you think about your patient's pain experience and it's primarily a local tissue issue, the evidence suggests that exercise and manual therapy is necessary to address whatever the local tissue needs are. There's also evidence that patients with acute pain will benefit from pain science education, and it can help, in fact, to prevent individuals from moving into a more persistent pain experience. There's a growing body of evidence that talking with our patients who are in acute pain about the pathology they experience is actually not helpful. In fact, talking about specific bulging discs and torn ligaments is likely to put an undue focus on the pathology, or the bio in this case, and that sometimes can slow the individual's overall recovery and progress. Now, that doesn't mean you shouldn't answer questions about their pathology or address any underlying concerns they have, but focusing on the specific anatomy and pathology is actually less helpful. I think understanding that patients with anxiety, depression, fear avoidance beliefs, and a history of catastrophization are individuals who are more likely to develop persistent pain is an important concept. A more robust intervention on the biopsychosocial side of things might be helpful for these individuals. Okay, so when treating individuals with nocioplastic-driven pain, pain education, exercise, and manual therapy are what the evidence favors. Manual therapy is a helpful way to facilitate descending modulation pathways and can help turn down a person's pain experience. Work by Vygotsky and his colleagues demonstrated that soft tissue mobilization has been shown to activate low-threshold A-beta fibers, which inhibit nociceptive input. Interestingly, deeper connective tissue massage has been shown to demonstrate an increase in the beta endorphin levels similar to the magnitude shown with exercise. So this may allow for endorphin production in patients who do not tolerate exercise. More conventional massage, including techniques like effleurage, have been shown to increase oxytocin levels following 15 to 20 minutes of soft tissue mobilization. But it does take that long to have that oxytocin effect. Additionally, there is evidence of increased production of both serotonin and dopamine, which indicates that the analgesic effect of soft tissue mobilization might be due to activity of the dopaminergic and serotonergic pathways. The effective manipulation and joint mobilization appear to operate on different pathways, and there's conflicting results over the beta endorphin levels following spinal manipulation, with different types of manipulation potentially utilizing different mechanisms. So the speed and location of the technique used may elicit a different neurochemical response and trigger different descending modulation pathways. It is important to note that some individuals with nocioplastic pain can experience allodynia and hyperalgesia, which makes them poor candidates for manual therapy. With these individuals, focusing on exercise and education, along with lifestyle changes and a goal of central downregulation, is much more likely to be beneficial. Manzano et al. In 2014 compared cervical and thoracic manipulation and found in both the cervical group and the thoracic manip group a decrease in neurotensin, which interacts with the dopaminergic system, and also a decrease in oxytocin was found. They also discovered an increase in orexin A plasma concentrations, and this actually helps regulate arousal, wakefulness, and appetite. And there is evidence that joint mobilization utilizes opioid receptor availability as its modulation strategy. It's important to note that patients with central sensitization have less opioid receptor availability to begin with, and therefore they are less likely to benefit from joint mobilizations if the goal of that mobilization is pain relief. There's a robust body of literature to support the benefit of exercise for persistent pain. You, of course, should use whatever exercise you deem appropriate for the patient's local tissue dysfunction, using basic therapeutic exercise goals to address deficits in strength, endurance, and motor control should likely be included in any treatment intervention. And when treating individuals with nociceptive pain, using aerobic exercise as a pain modulator has extensive benefits. Holtz et al. Examined the rates of physical inactivity and chronic musculoskeletal pain that demonstrated the importance of exercise in pain inhibition. There have been studies that have shown that people who exercise regularly experiencing less pain, even if they don't have any history of pain experiences. So the education grouping that Chimenti et al. Discussed seems to be the place where you can address any biopsychosocial concerns you might have. Adrian Lowe, who's a South African researcher, and Lorimer Mosley from the NOI Research Group, which is based out of Australia, have published extensive works on the benefit of explaining pain as a unique treatment strategy. Using that education strategy has been shown to directly decrease the pain levels of individuals with persistent pain. A 2016 study by Churkin et al. On the effect of mindfulness-based stress reduction compared cognitive behavioral therapy or usual care in individuals with chronic low back pain. And functional limitations that were found that mindfulness had significant effect in clinically meaningful improvement in patients with a global rating of change score, Roland Morris disability score, their back pain botherosomeness, and pain intensity levels, and their F12 mental health component scores were all improved. And they actually maintained this improvement at 52-week follow-up. So it was impressive. So Joe Neese's work, which was published in 2015, looked at the lack of sleep and found that limited sleep impairs endogenous nociceptive inhibitory function and increases spontaneous pain in healthy people. So these are people without any injury. They also found that sleep disturbances might not only perpetuate central nervous system hyperexcitability in people with chronic pain, but might also serve as a causational factor. So people who have no pain can train their nervous system to become more sensitive and more likely to generate a pain response by not sleeping enough. So a vicious cycle can easily emerge here where poor sleep lowers pain thresholds, which then facilitates hyperalgesia, which then causes poor sleep, and on and on and on. Okay, I think it's worth noting that individuals who you believe to have central sensitization are not likely to be ready to begin their intervention with exercise or manual therapy. There are folks who have had pain for extended periods of time, likely of hyperalgesia or allodynia, and have an inverse relationship to exercise. So that is, aerobic exercise that should decrease their pain actually makes their pain worse. You can test this by using an algometer or a pain to pressure threshold gauge, where you are establishing norms and you can tell if a person has an elevated pain response. Typically after aerobic exercise, those thresholds will improve, meaning it will take more pressure to generate a painful response. Individuals with central sensitization can have the opposite effect post-exercise. They require less pressure to generate a painful response. You can also use the Central Sensitization Inventory Scale, or the CSI, which is an outcome measure tool which helps identify people with central sensitization. A score greater than 40 is considered to be positive. We give every patient in our clinic, regardless of the acute or chronicity of their injury, a CSI as part of their initial evaluation paperwork. And it really helps us to identify very quickly who is likely to be at risk. If I find an individual has a high CSI score, a persistent pain experience and complains of hyperalgesia or allodynia, my exam is likely to include something like 2-point discrimination testing, graphesthesia assessment. The lack of precision that we discussed earlier in our talk today will certainly manifest itself here. So not only is their pain spreading, but their sensory integration is also less precise. So individuals who have a sensitized nervous system may not be able to start their interventions with exercise in the traditional sense, but will likely need to start by down-training their nervous system. Sensation training, including 2-point discrimination training, graphesthesia training, right-left judgment training, are all tools that can help improve that neural precision. Precaution must be taken here, even as this type of training, when performed in too high volume, can cause temporal summation. That is too much input to the nervous system, which also then provokes a pain response. So treating individuals with a sensitized nervous system that has an inverse relationship with exercise is complex and could be a whole webinar series in itself. Lorimer Mosley's work on central sensitization training has been extensive, and I would direct you to his book, Explain Pain Supercharged, for a more detailed description on how to use sensory integration training and graded motor imagery as a best practice integrate guideline option. Okay, so I don't think I can talk about pain science and pain treatment without a brief mention of opioid misuse and use. As I'm sure many of you know, the opioid crisis continues to rage across the United States. And according to the NIH, roughly 130 people in the United States every day die from overdosing on opioids. That's more deaths than occur with car accidents and gun violence combined. Gomes et al. In their recent JAMA article found that in 2016 alone, there were 1.68 million potential years of life lost to opioids in the United States. And opioids have been shown to be profoundly addictive, and this addiction occurs because of the effect the medication has on the nervous system. Dopamine receptors become overly sensitized, and there is a decrease in the excretion of that dopamine. With prolonged opioid use, changes occur in glutamate regulation, and glutamate is crucial in the formation of pain memories. And the increased glutamate production that opioid uses causes and facilitates more pain experiences. BDNF, which is a term you may know, is brain-derived neurotrophic factor, and that's decreased in the presence of persistent use. And this is important in neurotag resilience. So those neural networks that we talked about becoming less precise and more easily activated by their neighbors, that is facilitated by a decrease in BDNF. It's important to note that individuals with persistent pain and the nervous system physiological changes that go along with persistent pain are already primed to suffer from addiction. They already have these changes at baseline. So an individual who has persistent pain is actually more likely to develop a dependence on opioids because their system is already primed for that. The APTA's Choose PT initiative is another resource that you can use to help your patients who may have struggled with opioid misuse. Educating physicians who get little or no pain science education as part of their learning, educating patients and each other on why we can help experience pain and how we can revolutionize how we treat patients to help understand how persistent pains work and to help us move away from a pharmacological intervention which have proven to be minimally helpful and come at a great cost. So here are some resources that I have used over the years to improve my understanding of pain science and to help me better describe and explain it to my patients. Painful Yarns is a patient-friendly collection of short stories that discusses pain experiences and then gives a brief explanation of the science. It's a great tool for patient education, and I've used the analogies from there quite a bit. Adrian Lowe's Everyone Has Back Pain is another great patient-friendly tool. David Butler and Lorimer Mosley's Explain Pain and Explain Pain Supercharged are excellent sources for clinicians and are both texts that I have referenced extensively when I've been trying to further understand, further my understanding of the science and the physiology of my patients' pain experiences. So I'd like to thank you all for your time and attention today. We certainly appreciate all you do for our clinical students and our program. We feel very fortunate to have such wonderful clinical partners and look forward to our continued partnership moving forward. Thank you all very much. And here are my email. If you have any questions, feel free to contact me. On any of the content I've covered here today, I'm happy to review. And you can reach me at skmartin@bu.edu. And here are some of the references that I've used in the talk today. Thank you all very much for your time and attention.